Hello, good evening. Am I
Hi,
visible?
Dr. Neena. How are you?
I'm good, Shailaja. How are you?
I'm good, yeah. I'm still on the road. It's traffic is killing me. Trying to
Okay.
reach home, but I'll attend. Probably not switch on the camera, but I'll hear everything.
Okay.
So, Dr. Praveen has joined. Has she joined?
Should I try sharing my screen and see if that is
Yeah,
okay?
yeah. Please, please join. Please share. Yeah, it's visible.
Yeah, I think, but it's not started from the beginning.
Yep, yep.
Yeah. Oh, yeah. It's visible, right?
Yep, yep.
Yeah, yeah. Should I keep it like that or stop share?
Stop
Oh,
share for now.
oh.
Yeah.
Ma'am is Dr. Parveen is going to talk first, or whose talk is first?
Mm. Actually, I didn't ask anybody. You can start first if you're there. I'll just call her and ask her to connect. Hmm.
Today happened to by my OT. I finished early, so I'm in time for the meeting. Otherwise, I'm unable to attend. Parveen ma'am has joined, I think.
Okay, okay. Sure, sure.
Dr. Parveen has joined.
Yeah, yeah, she's joined, I think. Yeah, I can see her on but I don't know whether she's audible and visible.
Yeah.
Yeah. Hello, ma'am.
Hey, how are you, Nina?
Good, ma'am.
Is it a coincidence that both things are retina, or Shalita, did you plan it like that?
No, no, no. It's pure coincidence. I thought it'll be
Uh,
good. We'll have
Definitely,
ret,
definitely.
yeah, yeah,
Mm.
Actually, the kids, both
retina
of them
discussion.
they have retinal problems. So I thought, I mean, it's just good luck that you are here today.
Yeah, and Dr. Neema was saying that it's good that Dr. Praveen is there. At least I'll get some suggestions on my case.
Yeah, no, I try to attend quite a few as many as I can, or at least see the recorded version sometimes if you don't
मार्क्स
finish.
के बेसिस पे नहीं डिस्कशन किए जाए ये बोल रहे हो आप मार्क्स के बेसिस पे मैं नहीं
Uh,
Okay, so that was unrelated.
yes. So we'll just start with brief introductions, Ria, and Ria will do that, and then we'll start with Dr. Neena's presentation, and then move on to Dr. Parveen's presentation.
Okay. Do we want to wait for a few minutes or should we start? It is 6:30, 6:31 actually.
In 5 minutes, definitely we should wait, no?
Okay, we'll wait for a bit.
Yeah, just send it in a group that we have started, everybody, the link is active. Yeah.
Dr. Shelja, could you also make me co-host so that I can keep moderating and muting in between if anybody's got their mics on between talks?
Done, Riya?
Yes, thank you. Thanks.
Should we start now?
Yes, I think we should start. It will be 35 in a minute. So, hi and welcome everyone. I see more and more people are joining in by the minute, and by the time we have the talks going in flow, more people would have joined in. So, today we have both our talks related to the ocular genetics in retina, and for that we have Dr. Neena R. She is a senior consultant and the head of Department of Pediatric Ophthalmology, Strabismus and Neuro-ophthalmology at Giridhar Eye Institute in Kochi. We welcome you, ma'am. She'll be our first speaker today. And over to you.
Thank you, Riya, for that kind introduction. So, at the outset itself, I'd like to thank the Ocular Genetics Interest Group and Dr. Shailaja for this opportunity. So, let me start with my case. Can you see my slides and am I audible?
Yes, we can see your slides and hear you well.
Yeah, I've named my case as an uncertain evidence, unfinished business because I'm still unsure about it and I would like the expert panelist's opinion on this. So, my slides are moving.
We're still on the first one right now.
Why they're not moving? They were just moving right now.
Yeah,
Let
they
me.
were certainly moving during the trial.
I know
Maybe
that.
you share again, it should work.
I just stop share and do it again. Yeah, is it visible now?
Yes.
So is it moving now?
No.
Oh, you just try once again. What is it? It's just working right now. Yeah, I'll start with the slideshow from the beginning. Sorry, yeah. Now it's moving, I think, right? Yeah.
Yes, yeah.
So our child is he was brought to me 2 years back. So the story at that time, this was a 4-year-old boy whose parents brought him to me because they had detected refractive error in school. So when we saw him, his uncorrected visual acuity was 6/36. With effort, he could read near vision at N6 with effort. He could not comprehend anything on the binocular vision charts, but he did not have any manifest squint or nystagmus. Pupils were equal and reacting to light. Cyclorefraction revealed a mixed astigmatism in both eyes. He was otherwise a normal term delivery, normal birth weight, and he had normal milestones as per the parents, vaccinated for age, and there was no family history of any eye disease as per the parents. But they did give history of him going very close to the TV and watching the TV, for which they were very concerned. So, yeah. So this his anterior segment was normal. He wasn't very cooperative for slit lamp examination, but as much as I could see, it was normal. And this was his fundus. Fundus picture, we were able to get a fundus picture, and the media was clear. His discs were normal, the vessels were normal. And when we had a closer look, what we found was this area of, a large area of RP atrophy involving the macula. And there was an altered area of, you could say an altered appearance nasal to the disc also. The foveal reflex could not be made out. So there was this large area of macular, atrophic area. So this was his autofluorescence. It wasn't very cooperative, but that's what all we could get at that time. So at this point, we thought about a macular dystrophy, the commonest being Stargardt's. We thought this could be Stargardt's disease. So we asked the parents of any history in the family. They denied anything. And we were able to get a wide field OCT, which showed, again, altered foveal structure with foveal atrophy and loss of outer retina and EZ loss at the macula. So again, we were thinking, is it macular dystrophy? But it wasn't very typical of Stargardt. So we thought about other possibilities like cone dystrophy also. But child did not have any photophobia or nystagmus. So we told the parents to get some ERG genetic tests and further investigations. However, the parents did not come back for follow-up, and on further questioning the parents, there was no history of any difficulty in dim light or bright light, no hearing loss. And there was an elder sister who had no visual or systemic complaints. There were no skin or limb or hair or gait changes in the child. Child was moderately built and nourished. So again, this was our thought process. Let's get an ERG done, a genetic test done, and let's evaluate the parents and the sibling. However, child, they did not come back for follow-up, and 2 years later, just a month back, the parents brought the child with complaints of difficulty in school. The best corrected visual acuity, this time child was wearing glasses. We had given him glasses, but the best corrected visual acuity was only 6/18 N6 in the right eye and 6/24 N6 in the left eye. Color vision was defective. It was more defective in the left eye. He was able to fuse on Würzburger test with his glasses, and titmus fly was grossly about 400 arc seconds. Otherwise, anterior segment was normal. Fundus was as it was before. So again, this time on further questioning, the parents gave this interesting history of them belonging to a specific ethnic community, especially Kochi Muslim ethnic minority, and they revealed that they are first cousins. So these were some red flags in our history, and we decided to get him investigated further. We did a detailed OCT. RNFL didn't reveal much. The macular thickness was somewhat reduced, but over the years, it was kind of stable. The macular GCL also was thin, but it wasn't positioned properly, so we couldn't interpret much, but we knew there was definitely thinning and atrophy of the fovea. This was a fundus autofluorescence. Now, this gave us a lot of information about what he was having. There was altered hypoautofluorescence with a large area of hypoautofluorescence at the macula, surrounded by a ring of hyperautofluorescence along the vascular arcades. So this was not very typical of, Stargardt's also. So we were wondering, what is this that we're dealing with? Is it cone dystrophy, or is it something else? So we got an ERG done, and luckily the child cooperated, and you could see that he had normal scotopic responses and slightly reduced photopic responses, which were more in the left eye. So the left eye had the photopic responses more reduced as compared to the right eye. Again, it was not very typical of anything, but probably, yeah, could it be a cone road dystrophy? That's what we were thinking, or just a cone dystrophy, but not very typical. So we ordered genetic testing, and we had a big surprise on genetic testing. It came out positive for 2 genes, and the first one was Rho gene, or the rhodopsin gene, likely to cause autosomal dominant or recessive retinitis pigmentosa or retinitis punctata albicans. And the second one was ADAM9 gene, which is supposed to produce cone road dystrophy, but of uncertain significance. So the likely pathogenic variant which they described was a Rho positive gene. So that put us in a lot of dilemma, because Rho gene, these were the 2 genes which the reporting agency gave in detail, the Rho gene and the ADAM9 gene, and the Rho gene was reported as likely pathogenic. Yeah, so let's look at the variant 1. So the variant 1 in the Rho gene is supposed to produce retinitis pigmentosa 4 as per the OMIM 613731, and retinitis punctata albicans as per OMIM 136880. So this is typically, the retinitis pigmentosa typically characterized by pigmentary retinopathy or retinitis pigmentosa with definitely an abnormal ERG, and they may have inferior and inferonasal retinal pigmentation with a superior visual field effect, but they'll all have early onset night blindness, and some of them could be having cataracts also. Whereas retinitis punctata albicans definitely will have discrete uniform white dots over the entire fundus, maximum in the mid-periphery, but no macular involvement, and also they will also be having night blindness. But our child did not have night blindness as such. So we were still not very convinced what it is. So is it a different clinical picture in our patients, or is this a phenotype-genotype mismatch? We don't know. So let's look at the Rho gene, and the Rho gene codes for rhodopsin, which is a light-sensitive receptor protein. You know that it is important for the phototransduction in the rods and is very essential for vision in dim light. So when I read about this mutation, it can produce autosomal dominant, autosomal recessive RP, either by altering the transport of the rhodopsin protein, or it can interfere with the cell function and causing the cells to die faster, undergoing apoptosis, or it can lead on to CSNB when the protein is constantly turned on, resulting in CSNB. And eventually, they will also lead to death of cone cells and ultimately blindness, but that is a very that's quite late process. So we looked at the second gene, that is the ADAM gene, 9 gene, which is producing cone road dystrophy 9. Here, the typical phenotype would have early impairment of central vision, early onset of color vision loss, night blindness, and peripheral field loss usually follows late. They are typically thought to have widespread advancing retinal pigmentation, and some, the characteristic chorioretinal atrophy of the central and peripheral retina has been described. So some of the features our child had, like central vision loss, color vision loss, and some amount of atrophy in the central area. So these were, some confounders. So again, this is a metalloprotease protein, which is important in the addition between the RP and the photoreceptor outer segment. So any anomaly at the photoreceptor outer segment's RP junction can produce a problem and leading to progressive retinal degeneration, thinning of the outer nuclear layer, and again leading to deposition in the RP, and that is how the dysfunction happens. So again, we were confused. So I looked at the how much of genes they tested, whether the coverage of the genes was good enough. And to my surprise, there was a decent covering of all the genes, except for a very, 1 or 2 rare variants. Most of the genes were covered in the panel. I think I'm stuck again. Is it moving?
No, it's on the coverage of the analyzed genes.
Yeah. Yeah, now it's moving, right?
Yes, yes.
Yeah. So again, except for a few genes like the CRYAA and some rare genes like the, OPN1, I don't know much about it, but I found that they were not covered well. But most of the other genes were covered 100% by the testing. And even the mitochondrial genes were covered. So that's when we thought, let's look at the elder sister. So I requested the parents to bring the elder sister for a checkup, and they denied any problem in her. She had good vision. She was again having simple myopic astigmatism, but she had a good vision of 6 by 7.5 and 6 with glasses. Her color vision was good. So, but again, we thought this time that they also said the parents are, the parents are second cousins and their grandparents are again cousins. So there is deep consanguinity in the family. And the younger brother suspected with the retinal dystrophy. And on repeated questioning, the mother said the girl becomes very uncomfortable in dim light. So then we decided to dilate her and have a look at her fundus. And this is what I found to my surprise, that she had this, you can see this. She had this bone corpuscle-like pigments along the vascular arcades and in the mid-periphery. And the autofluorescence showed this typical pattern. The macular hyperfluorescence is okay, but there is an outer ring of hyperautofluorescence, and then again a large hypoautofluorescence. And again, along the arcades where there is the pigment disturbances, there is again hyperautofluorescence. So this was, very suspicious, and we requested them to test her further. And this was a OCT. OCT macula was okay. Outer retina was intact. But on the white field OCT, there was outer retinal loss and EZ loss in the areas that we were concerned about. So we decided to take her up for ERG, and ERG, she wasn't very cooperative for the ERG. She did move her head a few times, so we got some, some movement from the baseline, but nevertheless, it showed a reduced photopic and scotopic responses, and the scotopic was more than the photopic. The decrease in the scotopic responses was more than photopic and also more in the left eye. So this was all in favor of RP variant. And again, we were like, back to square one. We were not able to put these two clinical pictures together. So I'm in a diagnostic dilemma now. I have two genes which have come out positive. I've advised a genetic testing for the sibling and parental testing. And unfortunately, I couldn't draw a pedigree charting because there's a huge family. They're a huge family, and but there's a lot of intermarriage in the family because of the particular community they belong to. The parents are cousins. Their grandparents are also cousins. So that tells you that there is a lot of possible, genetic diseases which could be there. So now coming to the proband and all these things, how do I interpret the genetic results? How do I counsel them further? And what genetic test should I do in the sister? Should I go for a complete ophthalmic panel or test for the specific genes? And in the parents, what genetic test should I do? Is it again the whole exome or the targeted genes? I have a lot of unanswered questions. Thank you so much for the patient hearing.
Dr. Neena, wonderful and very nicely worked up cases, both the siblings. So I
Yeah.
definitely have a few questions and comments, but I think I'll first ask, Dr. Praveen's, comments on the cases, and also from many other attendees. There's so many other more experienced people who have joined today. So, Dr. Praveen.
Yeah, I think Dr. Neena very well documented and very well worked up. So I think this again is a very good example of genotype phenotype correlation. What is something which I am going to talk subsequently. that this is how it helps when we have to interpret our tests, and especially when you don't get a clear-cut answer on genetic testing. Though if I would say one of the most important things that we need to see when we are looking at children is that the disease may not be fully manifest in a young child. It just begins to happen. So if you could, think that which is most likely that the brother and sister are both having the same genetic disease, then probably the somewhat reduced scotopic and then almost near unrecordable scotopic in the older sister would probably show the progression, And if that is the case, then even RHO, which has been shown to be the likely pathogen, it could be the responsible gene. And considering that it is autosomal dominant as well, so, and a consanguineous family, so I think that could be a probability. Though I have not myself seen a patient of Adam 9, I have not seen, but probably any reason why they said Adam 9 was non-pathogenic? Would
Because
you?
I think it's quite rare. It's a very rarely reported condition, and they said it's not been reported in many cases. So I don't know, that is the reason. They said I did speak to their scientist, and they said you have to test the parents and the sibling. So there is no, the parents are not symptomatic, ma'am. They don't have any problems. But we have not tested them with ERG and OCT. I've tested them otherwise with regular visual acuity evaluation and fundus examination. They are normal, but I've not evaluated them with OCT and ERG.
But RHO, correct me if I'm wrong. I think what I remember correctly, it can be both dominant and
Yes,
recessive.
yes, ma'am.
So I think we definitely need to test the parents and of course the sibling as well, and that should give us more answers. So sometimes with what we used to do initially was test the families, especially when this consanguinity is there. So I think you will be able to match it up. If the Adam 9 is, I would want to know why they have mentioned it not pathogenic. If it is only due to lack of literature, then I won't write it off completely. Then you could be the first one to report. Or I think, if I'm not mistaken, some literature shows that it does, as you also discussed, it does show
Yeah.
broad
Yes,
distribution. So
there are some
not
reports.
totally unreported also. Or whether it is an autosomal recessive and they were only able to see the heterozygous state, or did they see
Autosomal
homozygous?
recessive, a homozygous variant they detected, but they have mentioned it as you know,
Non-pathogenic.
US variant
US,
one. So I
yeah.
wanted some,
Yeah. So
I mean,
just we need to check on that why it is non-pathogenic. And
No, it's
definitely we need to check the genotype of the parents and the sister will give us a lot of answers.
but ma'am, my doubt is from the phenotype of the child, the first child, what is your impression? Does it look like an RP or does it more like a cone road dystrophy to you?
So I don't like to use the diagnosis RP anymore, because RP has so many different kinds of presentations, and each gene causes a different kind of presentation. So if you think that RP is going to be typically only peripheral involvement, tunnel shaped vision, and good macular involvement, no, that's not right. There are so many genes which cause predominantly macular involvement along, and if you see the child also, there is a predominant macular involvement, but the periphery has never been normal. You have
Yeah.
a peripheral RP disturbance right from the very beginning. Same for the girl also. Though you see that ring and bullseye, you see the nasal area is affected. Even your case, first child also, nasal to disc, there was involvement already. So it is not only a macular dystrophy. Initially, in fact, if you just look at the macular dystrophy and you don't see the peripheral area, you may think it is a large CDHR1 kind of a mutation, or I was thinking whether any other systemic associations are there. But there is a peripheral involvement, and the typical thing that we see, constriction of field, that happens in some genes causing RP. But if there is already a macular involvement, some of them, so many like circle mutation, always they begin with macular atrophy already. So even ABCA4 would have a large macular atrophy and then go on to the periphery. So that's not necessary. I would say that just because it is. Yeah, Deepika, I think, wants to add something.
Yeah, hi. Thank you, ma'am. Good evening, everyone. A very nice case, Dr. Neena, and very nice, actually, very, very wonderful approach with respect to the siblings and how you have captured the images, everything. Very nice. If you can put back your slides, the last slide which where you had the questions. For me, like apart from what Parveen ma'am has told, if we look at the phenotype of the first child, the younger one, I feel that based on reported literature, it is close to Adam 1 or Adam 9,
Yeah,
based
that's
on the
right.
previous literature. And if we look at the elder sibling, it is a mixture because the autofluorescence pattern is matching to the Adam 9, and the retinitis pigmentosa phenotype is matching to Rho. So
Yeah.
probably it is known to happen that in consanguineous marriages, there is a double phenotype. So that is one possibility, like Madam was mentioning. And with respect to your question, how I would approach, I think others can also add on how they would do. Probe and how to interpret the genetic test results, thinking that it is a VUS and homozygous. And it is known that in consanguineous marriages, whenever there is a homozygous VUS, possible that if there is no other pathogenic causative gene, possible that it could be the phenotype. It could be responsible for the phenotype. So because the phenotype is matching to Adam 9, though it is VUS, we should dig further on the genetic testing. Like why it is called VUS, like Madam was also mentioning, whether it is like not at all significant with respect to the protein change, or it is of low frequency. What are the prediction models saying? What is the population frequency? Probably we can go further deeper and understand that. I think that will be the best approach to understand the variant itself. As of now, first understanding Adam 9 would be very, very good for us. So they report that cysteine codon.
Yeah, this is a report. You can see it. Yeah, what they've written is that it's not reported in 1,000
Not been
genome.
reported. So which is exactly
Yes.
what I said, that just because it's not been reported, you cannot
Yeah.
write it
Yeah.
off. So you may be the first one to report it in Indian
Correct.
population.
Yes, ma'am. I would agree
Especially
for that.
why, that
The
is why
most
you need to ask this question, why VUS? So if it is
Yes.
homozygous, as
yeah.
Deepika said, we really need to be very careful before we say that it is known to cause the disease. It is having some phenotypic features, which is where genotype-phenotype correlation becomes so important, because here you can drive, your phenotype can drive the genetic test. They may actually, if you're sure that this is phenotype looks like Adam 9, you can actually, they will actually convert it from insignificant to significant. So
Ma'am,
Yeah.
I'd just like to add a point in this part only. Since you mentioned that it's a very small community that they marry within also, and usually for a recessive, I will not ask for parental testing because both the parents will come out to be carriers and in heterozygous form. But it's worth inquiring if the parents' parents, so the child's paternal and maternal grandparents, are also consanguineous.
Yes,
Because how
yes.
that will help
Yeah.
is that if the parents come homozygous, it will help you rule out the variant. You might not get the answer if they are heterozygous, but just the likelihood that if the grandparents are consanguineous, they could be homozygous, could also be one way of interpreting the Adam 9 variant.
Yeah, their maternal the grandmothers are sisters.
Okay.
Okay.
So the
The
parents are
parents, yeah.
grandparents are also consanguineous.
grandparents also. Yes.
Yeah. And
So if we do
it
Sanger
could
for
possible.
Adam,
So like how do we so what do I do in the sibling? Should I selectively test for the Rho and the Adam gene, or just go for the and in the parents? Should I selectively go for these two genes only?
I
that okay?
think I feel for the sibling, we should go for a retinal dystrophy panel.
Okay, because it's looking like RP. To me, it looks like RP. Yeah.
Retinal dystrophy panel would be very nice approach to do. And then based on that, what we get in the sibling, then you can go back and forth with the parental testing.
Yeah.
That
The
would be the
siblings,
best approach.
totally asymptomatic till I prodded and prodded and prodded and asked her
Yeah,
when I saw those, pigments. Then they said, "Oh, she's little scared to go in the dark. She gets very angry." Otherwise, they were totally saying, "No, she's absolutely fine."
Maybe the parents also who are saying they're absolutely fine should have their retinas checked. You will get something there.
Autofluorescence.
I
Yeah.
checked there. I dilated
Yeah.
them and checked their retinas. They look normal to me, but I couldn't do a ERG and an OCT because without any obvious reasons, I wasn't suspecting it then. But now on retrospective, yes, I think I should get them.
Autofluorescence.
Autofluorescence would definitely help. That's what I said.
Autofluorescence more than anything else.
Yes.
So the first picture you
Would be
the first clinical picture, do you feel it is more like a cone road dystrophy or typical RP? Only the phenotype I'm asking, not the disease as such.
If you show the ERG of the first child, I think that gives you the indication that it is not macular dystrophy at all.
Yeah,
Yes.
that of course, macular dystrophy. Yeah, this is the ERG.
Yeah, so ERG is also subnormal, right? Even the scotopic ERG is subnormal here.
Yeah, it's slightly, yeah, it is. Now, then looking back, I could say that, yeah, maybe.
So, as I said, the age makes a lot of difference. We should not be in a hurry to, say that they are normal. You see them 2-3 years. How old was the sister?
Sister is 11 years old.
And the
Boy is
proband,
now
first
6
one?
years. He's 6 years now.
So 6 years
Yeah.
and 11 years, you already see 11 years it is extinguished. So maybe if you wait just another 5 years, this will also
Yeah.
be extinguished.
Yeah.
So
Even
like
I was saying that
breaking all
probably
the, yeah, please.
the younger one is yet to develop the entire phenotype. And the
Yes.
way you saw a mixed picture in the elder sibling, maybe that kind of a thing will develop in the younger one. So right now it's resembling Adam 9, but later on probably it'll be like a mixture, like the way the elder one was showing both RP features and a macular Adam 9 kind of a feature. So maybe that could be the reason. It's evolving. I think we have a raised hand from a couple of
Dr.
people.
Saveen,
We'll have
yeah.
quick comments and then we need to move on to the next talk. So Dr. Shrikant, you wanted to say something?
Yeah, I have a couple of points here. Like the
And
clinically,
Sableen, both one by one. Yeah.
clinically, if you look at the fulfilled ERG, so what Dr. Praveen also said, there is definite scotopic involvement, and along with that, there is photopic involvement. So probably since the child is very young, so it's very difficult to comment now on fulfilled ERG. But if you see the history of nyctalopia, it is classically pointing towards RHO as compared to Adam 9, which generally presents with CORD. So more predominant cone dystrophy. So initially they generally present with
There is no night vision complaint from the child or the parent about this child.
okay. Then it's very like I can understand it is a great dilemma this case, and I don't know, maybe we need to wait. It's very early to diagnose. So big general, I have seen like 4-5 cases of RHO. They present with dense nyctalopia to start with,
Yeah,
and
that's my
the
experience also.
yeah,
They
and
usually have night vision problems.
yes. So even in the first decade of life, they present with dense nyctalopia, and you see that even the scotopic 0.01 and 0.3, 3.0 are like generally very much extinguished. So, which is not the case in our case, in your case. Probably, maybe a mix of phenotypes, what Deepika was also saying. So it is worth looking at the parents also.
Yeah, so when I read about Adam 9, I don't have any experience with Adam 9. So when I read about, they're all from highly consanguineous communities. All the reports are from Turkish, Turkish, Pakistani, all these highly consanguineous communities. So that kept me thinking that whether is this possibly this variant, because they are also a community where a lot of intermarriages happen, and the phenotype was when I thought that time, it was more looking like Adam 9 rather than an RHO, because RHO definitely presents with night vision problem, and patients, or at least the parents, would notice a night vision difficulty. Even if the patients don't complain, almost all patients with night vision problems, somebody in the family would definitely notice that. That has been my experience. So that was what I was having a big dilemma about.
And thank you. We'll quickly have Dr. Sabline's comment also. I mean, she's been waiting for a while. Sorry. Yeah,
No
please.
problem. I wanted to ask, maybe Dr. Praveen can, enlighten us. If we look at the first OCT that Dr. Neena showed, the first OCT of the, the pro band. So what I have learned over the years, even before ERG, when children present with low vision, there is some photoreceptor loss, this foveal pit kind of thing that we see, loss of photoreceptors in the first scan that you see. I'm trying to zoom and it is in the OCT scan. So
Yeah,
even before
better one, I'll put it for you.
Before the ERG, normally we see the this loss of photoreceptors. No, this is in fact later. You showed the one at the first visit. So this loss of photoreceptor is actually very characteristic of cone rod. That's what I've learned. It can be generalized to ADM9 or even to other genes like causing cone rod. But to my, I don't know, I've seen one ADM presenting with this fovea. You see this black hyporeflectivity just below the fovea in the first scan. That's very characteristic. The scan above this one. Yeah, so this one. So just below the fovea, if you look at the line scan, there's this black small circle that you see. So this is what I've learned from my retina teachers, that this is very characteristic of cone rod. So even without ERG in a 4-year-old, I would keep cone rod as first. The phenotype. Please correct me if I'm wrong, or rest I agree with Deepika. Like, the elder sibling, we can do a gene panel. And this one I still feel is cone rod, but yes, as Shalja said, maybe, sequentially developing into something else.
I think good observation, but I think what you need to do, interpret OCT in toto with other things. So when you see patient clinically, also in autofluorescence, already there is visible, obvious loss of photoreceptor
I'm saying
at
this
the
even
at the
if it is
macula.
normal.
What
Yeah,
you're
even
talking of, that sign being typical of cone rod, is in cases of things like achromatopsia, where you may not have anything else. The fundus may be almost near normal looking, but the moment you do an OCT, you see that dark gap just under the fovea.
Is this
That
what you're
should
talking
indicate
about? Is that an optical gap?
Yeah, this one I'm not sure what exactly it is, because it is too small for me, and when I magnify it, I kind of lose
Yeah. Some optical gap has
contrast.
been described in ABC4 disease also, right?
Yeah,
Yes,
that's what. So it
yes.
is actually supposed to be that kind of optical gap. Is first is KCNV2, second is achromatopsia, and then acquired diseases like that Popper's disease and all those things. That is the typical DD that we read. But then that is most useful because clinically the fundus or retina may be completely near normal looking. And if you see this one, then you can immediately think of achromatopsia and ask for genetic testing. But here, in the presence of quite a bit of widespread atrophy, this is a part of that atrophic change. So now we
Dr.
know
Parveen,
that when, yes?
if I can add a point, like the classical subfoveal cavitation, which is optically empty gap, that is what you are mentioning.
Yeah.
Yeah, and I don't think this is a optically empty gap, and it is more of intraretinal than rather than subretinal. And OMD could be one of the differential diagnoses also, occult macular dystrophy.
Yes, yes. So these are few differential diagnoses for that typical subretinal cavitation. But here, when I enlarge it to see, I'm kind of losing the contrast. So I cannot be very sure as to what it is. And there seems to be some haziness below, some grayish echo is present below this cavitation also.
Yeah,
So I'm not sure whether it is just a artifact in the way the thing has been sliced or what it is. I'm not very sure. But what Dr. Sableen is mentioning, as the typically said, that's a DD of achromatopsia, occult macular dystrophy, KCNV2, and those kind of things, where you don't have any other changes, but only that small defect on OCT.
Okay, so thank you everyone. And that was a great presentation, Dr. Neena. I would like to draw your attention to the chat box. There are comments and questions for you there. And so we can move to our next talk with Dr. Praveen Sen. Thank you so much. And for our next talk, we have Dr. Praveen Sen. She is a Vitreoretina Surgeon and Head of the Retina Services at Agarwal Eye Hospital in Chandigarh. Without further ado, I'll hand over the area to her.
Yeah, thank you, Ria, and thank you, Shailaja, for putting up this wonderful ocular genetics platform where we can, kind of discuss our cases and keep getting encouraged that there are a lot more people like us who want to break their head over genetic diseases. Otherwise, it used to be such a lonely experience to sit and see these genetic reports and the phenotype. So I think my talk is almost, Dr. Neena has set the platform very well, because this is typically a genotype-phenotype correlation is what we are trying to do all the time. Because, and largely since our cohort or our Indian population is not very well genotyped, we have more of these problems of interpretation, because we are just beginning to be there. So I will talk of genotype-phenotype correlation, especially in retinitis pigmentosa and of course in some other retinal dystrophies. Though we say that IRDs are rare, but it is not actually so rare. Almost 25% of the blindness in working population is because of IRDs. And we have seen that more than 300 disease-causing genes can be associated with IRDs, which make our life more difficult. And the new standard of care in IRDs, especially in the absence of a definitive treatment, would be early diagnosis, characterization of disease, which is what is the phenotype, and genetic testing and counseling, that is genetic testing, and then some familiarity with the ongoing clinical trials so that we can correctly counsel our patients. So phenotype will not only include fundus photograph, but all of it, like we saw in Dr. Neena's case. The history is so important: visual acuity, perimetry, fundus examination, multimodal imaging, and electrophysiology. So there's a stress on both structural and functional assessment. And both the genetic testing and phenotyping kind of go hand in hand and complement each other. So where a good phenotypes helps us making a diagnosis, allows us targeting genotyping, helps us in prognosticating and understanding the disease. And in few situations, it can help us identify the underlying gene defect, which is what we were discussing in the previous case, that once we are sure of the phenotype, it can actually drive the genetic report and they can change it to what was a VUS to actually a significant gene mutation. So it is extremely important to develop these genotype-phenotype correlations so that we can precisely and diagnose and help our patients. So I'll just take you into a few examples. First of all, a few examples. This is for the benefit of my colleagues who are not retina specialists, because the retina specialists would probably know this. So there are 2 or 3 cases where actually, if you see the phenotype very carefully, it will lead you to a single gene diagnosis. It can't be like this one. This is the typical mid-peripheral kind of a torpedo-like lesions or circumferential subretinal pigmentation, which starts somewhere around the arcades. And then you have this typical kind of ERG, which looks similar, whether it is a scotopic or a photopic response, because there's only one kind of cell in the retina which is firing. So this is nothing but NR2E3 gene mutation, which is causing the enhanced S cone. And this is another one, which is what we were talking, the KCNV2, where you have a definite coin-shaped lesion. So this is a cone dystrophy. The moment you see cone dystrophy, you would expect reduced responses here on the photopic ERG. But here, when you see reduced photopic responses associated with supernormal combined 3.0 response in a dark adapted state, you can be sure that this is nothing but KCNV2. Where retinitis pigmentosa is concerned, it's a totally different ball game because there are so many genes which can cause it. Each one can actually present with a different phenotype, which is what I said, that very difficult to now say what is a typical retinitis pigmentosa because it is all driven by the underlying gene. I often say that retina has got, footprints of the gene on the retina. This is one place where we can actually see it with our eyes. So when we started doing this phenotype genotype correlation long time ago, this is the first one that we reported, which was the circle, which was most common, especially in North Indian population. And now having moved to the north, I realized that this is actually very common, and this is initially what surprised me, because here retinitis pigmentosa, the moment you say retinitis pigmentosa, you expect the central area to be uninvolved. But here you can see this is usually the first thing to get involved. Large macular area is involved, and with this well-defined coin-shaped lesions. And this is not gyrate or anything. Believe me, this is nummular CRA patches in the periphery, and this is very typical of circle mutation. So with this thing in mind, when I came to this part of the country, I saw a 35-year-old male with a high myopia around -8 and diagnosed to have myopic degeneration. No history of night blindness, some color deficiency was there. ERG was poor quality, but still recordable, not totally unrecordable. And then when I saw, this is how it looked like. It had a macular involvement and then a healthy looking retina in between. And then you see the periphery, this kind of well-shaped circular areas of atrophy. And I suddenly thought of circle. And I asked for a genetic testing, and definitely circle mutation was pathogenic, likely pathogenic. And this was a circle causing retinitis pigmentosa. But to make things worse for you, circle is not only the only one which gives you these kind of nummular CRA patches in the periphery. You could have it with PROM1 gene as well. And again, this comes with early macular involvement, or you could have with RP65. Only difference is circle is relatively paucity pigmentary. You will not have that much of pigment. Here you see more of pigment. So these are few things you can keep in your mind. And then, of course, if you get a definite diagnosis, great. But if in presence of this kind of phenotype, you get a circle which is of VUS, then you can tell them, no, this looks like a definite circle mutation. So this is another one, that RDH12. This is again a very typical phenotype. You have this almost punched out kind of a macular scar here, non-recordable ERGs, and look at the OCT. This gives you that coloboma kind of appearance at the macula. So this is very, very typical. Many years ago, I was just in a few years in my retina practice, and there was a patient who had been diagnosed to have RDH12 from Moorfields, and he came into the OPD and they wanted to have an exam. And they said, I don't know how, but the doctor, the moment he saw the retina, said this is RDH12. So now you know why it is like that, because the appearance is so typical that you cannot miss it. This typical colobomatous like feature at the macula is definitely RDH12. Then we all know that we have read so many times that there are cystoid changes in retinitis pigmentosa, and it was earlier believed that this is inflammatory. Then it came that no, this is non-inflammatory. There is no leakage, but maybe some kind of inflammation is happening. But actually now more and more understanding is that these changes are due to changes at the vitreomacular interface, and they are also gene driven. So this is the autosomal dominant type of RP, the PRPF31. They are known to have vitreomacular interface, and this could be the underlying cause why there is associated CME. This is another one which has almost a full thickness macular hole formation, and was actually referred to me for macular hole surgery. But when I saw these changes in the periphery, I asked for an ERG, and this is how it looked like. And then very sure that I'm dealing with the mild form of RP, or an autosomal dominant form of RP, advised genetic testing, and we did come across autosomal dominant mutation in PRPF6. So this kind of, whenever you see vitreomacular interface disturbance, whether it's in form of cystoid macular edema or macular hole, you can think of one of these mutations. The type of pigment, we have always heard bony spicule. It's not always bony spicule. Look at this fine pinhead kind of pigmentation, and look at this when you see closely. This is the nummular coin-shaped pigmentation. Very first time when I was years ago trying to look at phenotype genotype correlation, I didn't know much about it, but when I suddenly saw 7/8 crumbs CRB1 gene mutation positive RP, they all looked identical, and I had goosebumps. I said, wow, this is what genotype phenotype correlation is all about. So this is very typical. Another typical feature is, early macular involvement, and then there is para-arteriolar sparing of the RPE, which is typical of CRB1. This we know when you have a 36-year-old female with a history of deafness and night blindness, you think of Usher, and I did do genetic testing here, which showed us USH2A. But we all know that USH2A usually has macular sparing, and patients are able to maintain almost 6/6 vision for a very long period of time. But this is another example of a patient who has paucipigmentary RP, but macula is spared. But then this example, you see the patient did have USH2A, but suddenly he deteriorated from 6/18 to counting finger within 3 years. And the USH2A gene could not explain this, because macular atrophy is not a part of USH2A, especially early on. But then when I looked carefully at the genetic report, there was a VUS at CRB1, and look at this calcareous like deposits at the disc. You see this para-arterial sparing of the RPE, and this is very, very typical of CRB1. So those CRB1 as genetic report was VUS, but it definitely was manifest on phenotype. And this is almost like a double hit kind of a RP, just like what Dr. Neena, the case she showed us, that sometimes more than one gene may come together to cause the phenotype and confuse you. This is another one, the ABCA4. So much is the typical change with ABCA4 that we know that sometimes it can cause only Stargardt's, but other times you may have a nicely atrophic macula, and then you see some healthy RP around the disc, and then you have this RP alteration which are breaking into the periphery. So typical is the presentation that now we don't call it cone rod, we don't call it rod cone, we don't call it RP, we call it the ABCA4 retinopathy. And I think we are not far away from a time when we will start calling it RHO retinopathy. We'll be so sure of our phenotype and genotype correlations that it'll be more definite and no retinitis pigmentosa. And this again, as I said, ABCA4, usually you see this peripapillary sparing. So even in advanced cases, you can see peripapillary sparing of the RPE. And this is again a feature of ABCA4 genetic mutation. And then, of course, when you are so sure of your phenotype that this is a phenotype of retinal dystrophy, yet if the genetic testing comes out to be negative, you can do a whole genome with confidence, because you know that this is what you're looking at. And actually, if you find something different, this will be a new gene that you would be looking at, and you will add to the literature. So this is again very important, where all of you play a very important role, because a lot of you are pediatric ophthalmologists, and you may be the first person to see these cases even before they reach the retina specialist. In a study that we had done, almost 10% was seen to be syndromic, and especially things like Sinner-Loken syndrome can be caused by ICQB1. And here, the important thing to remember is that ocular features may be the first to develop. And if you identify this gene, you can warn the patient or the parents to go and be under care of nephrologists, so that the damage to the kidney can be limited. But of course, you must, as we saw, that the disease evolves with age. So this is another problem in the pediatric age group, that you may not have a fully developed phenotype present if the child is very, very young. This is another example, very nice one, which I came across here. The child came to me in Chandigarh, almost 11-year-old female child, had been already had a history of pulmonary stenosis, had multiple times retina checkup, and retina at 1 year was shown to be almost normal. And earlier, the child had photopic responses which were reduced, then scotopic were normal. child was diagnosed first to have normal retina, then diagnosed to have achromatopsia, then diagnosed to have cone dystrophy. Clinical exam done in 2021 was negative. But I was so sure that we are probably suspecting a senior look-in because patient had by 11 years already undergone a renal transplant. I mean, how can that not be related to her retinal dystrophy? So I advised a whole exome sequencing once again, and once I did that, again I came up with no clinically, pathogenic variants. But when I looked into detail, there was a CEP290 which is known to cause senior look-in, and this was present, but it was in heterozygous state. For it to be significant, it should be homozygous because it is autosomal recessive. Now there was a hunt for another allele. How do we find it? And when we did, the parents were very keen to, they were ready to go anywhere for gene therapy. And knowing that CEP290 clinical trials are going on, when I started reading, I realized that I took the help of my genetic counselor here, Dr. Meenakshi. I don't know whether she's on this call today. And we realized that this is an intron for which gene therapy trials are ongoing. And we had only done an exome testing. So we either could do a whole genome, which could have given us the answer, or more importantly, we specifically asked the MedGenome people who did the testing for us to look for this specific intron only, because if this is present, they could think of getting enrolled for the gene therapy trial. And if it is negative, then obviously they are not eligible. So unluckily, this intron was not present, it was missing. But I'm still looking for further analysis we are doing. And though I don't have the slide here, we have seen that there is another variant which is probably seen in the BBS1 mutation. So I don't know whether it's a digenic with BBS1 and CEP290 coming together to give us this phenotype. So this gene testing doesn't happen at one step. You go to the first, go to the next. So now the parents are getting evaluated to see. And I have not been able to answer the other question, whether you could have a sibling which would be affected. So far, this is the only child. So for which reason now we are having the examination of the parents. Again, to make problems worse for us, one gene can cause different phenotypes, and we know pasteurinopathies are a perfect example where the VMD gene can cause 4 different phenotypes. And the same here, as we discussed, ABCA4 can cause Stargardt's, can cause cone rod, or can cause RP. And then there are phenocopies. So we know that Stargardt's can be caused by ABCA4, but we also know that other genes called like the prominent 1, the PROM1 or the PRPH2 or the L4, they can also be the causative agent for Stargardt's. So genetic testing and phenotype, all that has to go in hand. And not only that, the severity of of the disease. So this is, we know, X-linked retinoschisis. This is the typical presentation, but this is not always the case. We have seen it is varied. It can vary from huge cysts which lie just behind the lens in children who are less than a year old, and you can have large splits. So, and not just foveal schisis. So there are studies which have shown that it is a type of mutation. So suppose a missense mutation may be more severe, a null RS1 genotype will be even more severe visual outcome and associated with more than almost 8-fold odds of poor visual impairment. So I would just conclude. I hope it's not been too difficult to understand a lot of things, and deep phenotyping is necessary for better understanding of disease. And this importance of accurate genotype-phenotype correlation cannot be overemphasized, particularly as new therapies are coming, and particularly now that more and more of us are doing gene testing. Thank you once again for this opportunity.
Thank you, Dr. Praveen. That was a wonderful talk. Am I audible?
Yes.
Yeah. So that was really wonderful talk, and it really speaks about the years of experience that you have had dealing with these inherited retinal dystrophy patients. So many learning pearls from this single last 15-20 minutes, and even from Neena's talk is like I'm really so happy about this webinar today. I think there'll be questions in the chat and there'll be people who will be wanting to ask. So over to Ria, take up some questions from the chat. And if anyone wants to speak, just speak up. This is an open forum kind of a thing. We can really make use of that.
So there was this question on the chat from Harleen saying that since proband is from consanguineously married parents and we are suspecting autosomal recessive, do we have to search for the other variant of the Rho gene if we are looking for it to be, pathogenic? The report, they said it could be autosomal dominant or autosomal recessive, but yeah, it looks like autosomal recessive because the parents are not manifesting any clinical disease. So in that case, for it to be pathogenic, we need to have the second variant, right?
Ma'am, actually, the variant which we found is for sure likely pathogenic, but we have to check what are the for autosomal dominant, for autosomal recessive disorder, in genetics, we have different pathomechanisms. So we have to check whether this variant is reported in autosomal dominant fashion or autosomal recessive fashion. If it is reported in autosomal dominant fashion, well and good, it explains the phenotype in our proband. But if it is reported in autosomal recessive, then we might have to look for the other variant as well. And if
So
we are
they have
yes.
reported they have written it is reported both as autosomal dominant and autosomal recessive.
Ma'am, that is for the disease. I'm not sure if for the particular variant they are talking about an autosomal recessive or dominant. The gene is associated with both fashions of autosomal dominant or autosomal recessive RP, but this particular variant is reported in autosomal dominant or recessive. We might have to, I'm sorry for the confusion, but we might have to see about it.
Yes.
And the other thing is, if we are doing testing in parents or in the other siblings, that can explain the thing as well. Like if any of the parents have this particular spelling change in their RHO gene and non-manifesting the disorder, then we might have to rule it out.
Okay. I'm not very good at genetic, understanding. A lot of this itself has taken a lot of, understanding for me. So I think I would have really appreciated if we had a geneticist or a counselor at our place. But sometimes we have to sit and, split our hair and then answer the parents' queries. So thank you so much. I learned a lot from today's discussion.
Thanks a lot, ma'am.
This is what I think this club has done. It has helped us get in touch with so many geneticists, and every time I listen, I learn so much because you wouldn't have thought of it this way. So for us, for me also the journey started by just looking at the gene defect present, not present. No, it is not so simple. If it has to, it is heterozygous, it is homozygous, it is present in the parent, is not present in the parent. You have to explain how it manifests the disease. Only then can you call it pathogenic. So I'm also learning every day. And get hold of somebody, if not in the same place, Neena, get hold of somebody virtually to discuss these cases. I think it will really be helpful. And it will be helpful both ways. Believe me, they will also learn from you.
Yeah.
Yes, thank you. I think we'll have some final comments. So we have hands raised by Dr. Deepika and Dr. Shrikant. So you can unmute yourself and.
Thanks, Ria. Shrikant, I'll go first. Is that okay?
Yeah, Deepika.
Yeah, thank you. Thank you, Dr. Praveen, for like it was a capsule of IRD and phenotypes. I had this one doubt on the ABCA4 which you showed. Like it had that huge RPE demarcation in the mid periphery and beyond. Like, was it seen in autofluorescence in a different pattern? Did we have hyper autofluorescence or some flecks within that region close to posterior pole? How was it? This is the first time I'm seeing ABCA4 with that huge demarcation of RP.
Yeah, so actually, I think this probably starts as a macular scar. You will have that, what we used to call initially as the central RP with the bony spicule present pigments in the center. But then if you start looking carefully in the periphery, you will start finding some RPE changes, little pigment here, little pigment there. And that is what I think happens. Then as that peripheral pigment starts expanding, then you are left with only a broad area of kind of a healthy RPE in between. And now with ABCA4, I think I have learned that it can be really varied. It can grow slowly from center to periphery, or it can present like this. But finally it coalesces and shows this kind of presentation. But I think I have seen it before also, and it
Is
somehow
it
doesn't surprise me.
recessive then RP, the ABCA4 is it
Recessive.
yeah, I've also seen autosomal recessive because a patient was referred as Stargardt's, and
And then you see in the periphery, you see the
periphery, this-
pigment, and then over a period of time, it goes on increasing in area.
Okay, thank you, ma'am. Just to add to CRB1, we also see increased retinal thickening in the OCT. This is also very classic of CRB1. Unlike other dystrophies where we see retinal thinning, CRB1 is known to have a thickened retina with poor differentiation because it is called as remodeling of the retina once the degeneration starts. That's all from my side. Thank you, ma'am. Thank you, everyone.
Thank you. So OCT in IAD is a totally separate lecture, maybe someday. That is a different one.
Yes, yes.
Yeah, agree. I think all the multimodal imaging, each imaging and each diagnosis in retina, and even in anterior segment, maybe we could have, that gave me an idea that we could have capsules where one of the talks could be one imaging modality and the other one could be, genetic related case or something. That also we can integrate into these webinars.
Yeah.
Shrikant.
Yeah, thank you, ma'am. Thank you for the wonderful talk. Like I want to add 2 points, like what Deepika told regarding CRB1 also. Like it generally presents with also cystoid macular edema, and sometimes you will see classical codes like response in CRB1
Yes,
along
correct.
with those PPRP. And regarding peripapillary sparing, and this is also classically seen in RDS12. If you see, and we have reported a case of RDS12 with peripapillary sparing along with these amoeboid-like lesions. It sometimes this presents looks like serpiginous like choroiditis, and this has been classically described in the literature as variegated watercolor appearance in RDH12, along with what you showed pseudocoloboma. And pseudocoloboma is nothing but if it arrests the macular development. Also in seen in like other dystrophies like RD3 mutation, where classically you will get only pseudocoloboma or maybe advanced stage of dystrophy. And regarding those ABCA4 related data, what you showed, the advanced stage of ABCA4 with which presented like maybe like gyrate atrophy, like patches, large spaces. This is seen in RP19. This is the matlab, uh, end spectrum of Stargardt, you can say, not Stargardt, ABCA4 retinopathy. And the milder version may be CRD, and the mid version may be the Stargardt, and the end version may be the RP19. Same gene, but different phenotypic expression. Yeah. Thank you, ma'am, for the wonderful presentation.
Thank you, Shrikant, and thank you, Deepika, for your wonderful inputs.
Thank you everyone for today. A lot to learn, ma'am. Even I mean, while you were speaking, I was just thinking about my reports and what the patient came with, and it all sort of we could sum it all together. And thank you so much to both our speakers. And we will see everybody next month for our next session. And thank you so much.
Thank you. Thank you, everybody.
Thank you. Wonderful talks again. Thank you so much, Dr.
Thank you,
Praveen
Neena,
and
for a
Dr.
nice case. Thank you.
Thank you.